Hi, I'm Dr. Goran Stankovic, interventional cardiologist from Belgrade, Serbia, and warm welcome to PCR Webinar, How Should I Treat a Left Main Stenosis? Focus on the stenting technique. To discuss this challenging topic, we have great faculty today. First, Dr. Thierry Lefebvre, who is really one of my closest friends and teachers. Thank you, Thierry. And the other one, Professor Hui Chin Tan from Singapore, another expert from Asia Pacific region, one of my frequent co-chairs and moderators at EuroPCR. I feel very comfortable and confident with two true experts for left main PCI to discuss this complex topic. Please show us the learning objectives. So what we are trying to do today is to discuss different stenting techniques for distal left main bifurcation lesion, to try to understand how to adapt treatment strategy to underlying anatomy, and to learn the procedural steps of distal left main stenting. Please use the chat box to ask your questions. We will be very happy to try to address all of them. So as usually in Bifurcation Continuum Series 2020, we start by case presentation and we try to understand the pathology and the reasoning for making decision regarding strategy. So Thierry's floor is yours. Please show your case.
Thank you very much, Goran. It's really a pleasure to be part of this continuum in bifurcation. So the case that I will share with you is a woman, 86-year-old, with diabetes and high blood pressure. She had a moderate effort angina since 2 years and recent accelerated angina, and then prolonged chest pain of 30 minutes with troponin elevation. Renal function is not optimal. This is usual in this kind of old patients. Now, this is the EKG 1 hour after this prolonged chest pain, and you can see that there is a huge ST segment depression with some ST segment elevation in AVR. So it means that it's really a severe coronary disease. Now the coronary angiogram was done the day after the admission. She had severely recurrence of chest pain during the first 24 hours. And you can see that there is calcification, severe distal left main disease with a short lesion of the proximal AD and a long lesion, very irregular, of the circ, which is the big territory. Now this is an aerial view showing that there is a lot of disease at the distal left main with calcification, and this involves the proximal left main too, which is smaller than it should be comparing to the size of the LAD and circ. This is a spider view which shows the complexity of the lesion and maybe complexity of access toward one of the two branches we'll see. And this is the right, which is also diseased with calcification, two tight lesions, relatively short. And look carefully at this, right, because it gives collateral from the PDA to the LAD. And I think this is a very important point in the discussion on the strategy. So we had a team discussion. Of course, the surgeon said, no, we'll not do anything to this patient because she's too old. Syntax score is 36. Renal function is not good. So we had discussion about the strategy for PCI. And after a long discussion, we decide to go to PCI. And you can see that if you make the calculation of syntax score 2, you can see that we estimate the mortality after surgery 44% at 4 years and PCI 17%. And if you add medical treatment, probably it will be 50% at 6 months. So maybe we can start to discuss about the strategy in this case. The first point is, should we use intra-aortic balloon pump in this particular case? I don't know what you think, Goran.
considering acute coronary syndrome presentation, really very severe and diffuse disease, very tight lesion, distal left main and both osteo of the LAD and the circ, plus significant lesions in the right coronary, I would consider prophylactic balloon pump use in my life just in case that something goes wrong. I don't know, Prof. Tan, what do you think? What would be your approach?
I completely agree with you. In somebody who just have a recent acute coronary event and such marked ST segment changes on the ECG, I think some kind of mechanical circulatory support here will be very helpful.
Okay, the second question in this particular case is should we use rotablator toward the LAD or the circ or both, or should not use it? And I think it's a big question because you have seen that if we have, because the right is severely diseased, if we have any problem with rotablator in the left main, the patient will go into big trouble. So our strategy was to start with a non-compliant balloon to see if we can expand the lesion with a non-compliant balloon. If not, of course, we will have to move to rotablator. But if we are able to expand, we'll not use it in terms for safety reason. The other question is the right. Should we start by treating the right, or should we treat only the left main and maybe the right after? What do you think?
Yeah, you mentioned, yeah, please, Prof. Tan, please.
I'm just thinking that this patient has got a very severe left main disease, and clearly on ECG, this appears to be the culprit lesion. I think in this setting, I will go for the culprit lesions, which is the distal left main bifurcation lesion. With regard to the use of device for lesion preparation, actually, I would consider some form of imaging to help me in deciding on the strategy. I think imaging will help me to tell me what sort of lesion am I dealing with. Is this a concentric calcifications, or is this superficial or deep? Because it's going to help me decide on what sort of lesion preparations and devices to use. Plus, IVUS or any form of other imaging is going to be helpful in terms of optimizing results. So I would do the left main first and image, and followed by strategy.
We already started receiving questions from our audience. Rafal is asking, should we use Impella? It's very high risk case. And Dr. Ashish also, why cannot we use Impella? Thierry, what was your thinking regarding use of Impella?
I think Impella can be a useful approach, but in terms of safety, it's safety about the femoral arteries. In an 86-year-old woman, maybe it can be a problem. So I think we can have Impella in standby. Yes. In my opinion, intra-aortic balloon pump is a very good approach in this particular case. You have a very high diastolic pressure elevation with a balloon in this kind of patient.
Another question was asked, sorry, Thierry, by Dr. Binayak Deb, pre-procedural imaging to see the extent of calcium. I think Prof. Tan already commented. So please proceed, Thierry.
Yeah, I will comment on that because I anticipate that it will not be safe to use intracoronary imaging in this particular case because of course, you will not see everything, but when we start to do balloon angioplasty on this lesion, the pressure drop in 10 seconds from 14 to 5. So I think that by using intracoronary imaging, we'll have the same problem. And of course, you need more time to do good imaging. So of course, you can pre-dilate and do imaging, and then it will be safer. But starting with intracoronary imaging, in this particular case, may be dangerous.
Okay. What was the next?
So what about the right? We have we have already discussed. Intracoronary imaging, we have already discussed. And of course, the last question is which stenting technique? So should we use 1 or 2 stents? And which branch first? And which strategy?
I think Prof. Tan should start, and then I will add my opinion. I'm sure in such complex and diffuse disease, we should simply naturally have diversity of opinions. And I would like to all three of us to express, Prof. Tan, what would be your strategy in this case?
This is an incredibly complex lesions, and it fulfills every bit of the criteria for complex lesions in the definition 2 trial. This is a lesions with calcifications, with very long disease, with very tight blockage in the side branch. I will go straight for a 2-stent strategy here. And I think the 2-stent strategy with the most data at this point in time is a DK crush strategy. So it is something that I will try it out, start off first. And I will begin with doing circumflex first, followed by the LAD.
Yeah, thank you very much. I agree with you that 2-stent strategy is something that everybody is expecting in this kind of complex anatomy in both vessels. My personal approach, and it's based on experience which I have with culotte, will be probably to use culotte. So whether it's inverted culotte or it's a straight provisional culotte starting from left main towards the LAD, as Thierry nicely pointed out that it was not clear to me in the beginning, is complexity of access to LAD. So probably protecting LAD first and then culotte with minimal overlap inside the left main would be more or less my strategy based on anatomical complexity and my personal preference regarding 2-stent technique. Thierry, what you decided yourself, this is what counts most.
Yeah, of course. So I try to summarize the option that we may have in this particular case. So it's a true bifurcation lesion. I think we all agree that we need 2 stents to treat this lesion correctly. So no doubt about that. Our strategy, and this is a consensus from EBC, is that it's based mainly on the risk of side branch occlusion. And of course, if you have no risk of side branch occlusion, you go to provisional approach, do a POT, provisional side branch stenting. So it's a step-by-step approach, increasing the complexity of the procedure. And at the end, you can do a T-stenting, a TAP, or a culotte. Now, if you think that there is a risk of side branch occlusion or main branch occlusion, then it should be a different strategy, of course, especially for the left main. So, of course, DK crush technique can be a very good option in this kind of case. But you can also do inverted provisional, stenting first the branch which is high risk of occlusion. And then with inverted, you go back to these different strategies, which is inverted T, inverted TAP, or inverted culotte. So in this particular case, we thought that the risk of occlusion of the circ will be very low. So we start with a provisional approach, but of course it does not mean that we'll end the procedure with only 1 stent, because we start with the idea that we will use 2 stents in this case. So remember the lesion. I think it's very useful to reconstruct the anatomy of the vessel, and when you do it, you immediately understand that circ will not be so easy, so difficult to access, but LAD may be very difficult, and it was exactly the case. So we were able to put a wire very easily in the circ, but access to the LAD was difficult, and I had to use a Fielder FC wire with a big angulation in order to access toward the LAD. And this is the Fielder FC. You see the angle that we have made, and then we access the ostium of the LAD with some difficulty, and then we had to make a turning wheel in order to be able to go more distal in this LAD, as you can see. This is a very useful tips and tricks when you have this kind of difficult access.
Thierry, if I may add, in my opinion, I frequently use in this kind of anatomy dual lumen catheter, having wired circumflex, and then with over the wire lumen for dual lumen catheter, it's relatively easier as another level of complexity.
Absolutely.
Please continue. Please continue.
I agree. So then after wiring both branches, we use a non-compliant balloon, which are able to open the lesion on the LAD. So where AP not to have to use a rotablator in this case. And then after predilatation, you see that now we have a better aspect of the LED. Then we stent, and of course we pay attention to go to cranial view to have an optimal positioning of the stent up to the ostium of the left main. And we use a long stent, 3.5, in order to be able to increase the size of the left main at the level of the stent at the level of the left main. So then we have deployed the stent at low pressure. Of course, at the end, we'll do a kissing ball inflation. So we go to low pressure because the LED is not 3.5, but more 3.0. Then we do a proximal optimization technique with a 4-0 balloon. And after that, you can see the result. So left main now is bigger than it was at the beginning. The LED is okay. And then we went through the distal strut. Okay, so you see the distal, the wire going into the distal strut, and then exchange wires, open the strut toward the circ, and stent. And you can see that it's very important if you make hesitation between T and tap to look at different views. So in this view, we have the feeling that we have some overlap, so it will be a T. But if we go to the spider view, you can see that we have, without moving the stent, we are really at the perfect position for doing a T and not a tap. And of course, I prefer to do a T if I can, because there is no neurocarina proximal to the bifurcation. So then we have deployed the stents. Then we have done kissing ball inflation and a final pot with a 4.5 balloon. And you see the positioning of the balloon just proximal to the carina. So this is a final result in the left main, which looks very acceptable, I think. I have to say that when we have, or at the beginning of the procedure, where each balloon inflation, we had the pressure going down in a few seconds. So it's really, despite intra-aortic balloon pump, and we saw the diastolic pressure increasing with intra-aortic balloon effect. The final result, which looks very acceptable. So the procedure was a little bit challenging, of course, a little bit more than 1 hour procedure. 137 cc of contrast media. The patient was discharged 2 days after the procedure. And of course, we plan to do the right 3 weeks later. So this is, the patient came back. She was totally asymptomatic. This is the result at 3 weeks, which looks very good. And of course, we have treated the right with 2 stents. These 2 lesions, you see again a lot of calcification, but we were able to treat it without a rotablator with good non-compliant balloons. And this is the final result. So maybe you have comments, Goran, Dr. Tan, or yes. Maybe we have questions from...
Yes, let's first ask, there are multiple questions coming through your presentation. I would like to try with your help to answer as many as possible. So to make a group of questions, some questions are related to lesion preparation. You discussed why not you decided to start with the rota. Questions are coming regarding shockwave, intravascular lithotripsy. What is the role in such complex anatomy, and how you make distinction when to use rota, when to use IVL, or sometimes when to combine the two?
Yeah, I think it's a good point, Goran. And of course, shockwave was in standby. Of course, we'll not be able to go with the shockwave as a first balloon, but in case of mal-expansion of the stent, I plan to use it. I think it's a very good tool to treat this kind of lesion. It's relatively safe. The only problem is time of inflation, which is at least 15 seconds, because you have 10 seconds of inflation. So, of course, you can give some waves in less time, but you need to do a lot of inflation and then a few activations. But I think it's a very useful tool in this kind of lesion, if necessary.
Yeah, Prof. Tan, do you have any comments regarding lesion preparation? Would you do something different? So Thierry decided to do non-compliant. As we see, there was full balloon expansion, and he decided to stay with NC balloons. Would you use still imaging, or before ROTA or ROTA? What would be your strategy?
So my strategy here will be to do a pre-dilatation first and then put in an IVUS to see what's going on here. Certainly, if it's a very calcified lesions, I agree that ROTA will be a very high risk. Plus, already I have pre-dilated the lesion. It will not be a good thing to rotablate after that. So shockwave lithotripsy will be my my choice of device in terms of preparing this calcified lesion. So I will keep it on standby, but certainly I really would like to have some image guidance here.
Okay, there is a second group of questions, of course, related to imaging. Thierry, you discussed why not to start with imaging, but then there are multiple questions whether we should use imaging after stent to evaluate the result. And another question, I don't want to miss this one. When you use T-stent on the circ, should you leave uncovered calcific ostium? How you make sure to cover completely the ostium? Some tips and tricks and why you decided, please. I think it's very important to clarify for our audience.
Yeah, I fully agree, Goran. So there is many tips and tricks. The first one is to have a good view to see the bifurcation and to position the stent at the right place. Also to know where are the marker as compared to the stent. And sometimes you have the marker outside of the stent or marker inside the stent. So it depends on the stent that you are using. And the last point is that if you have any doubt about the positioning, of course you can do a tap. But there is a very nice way to position is that you put the stent at the right place. You think it's the right place because you have the good view to see it. And then you inflate the balloon in the main branch. And you see that if you are in a good position, you see that the stent is exactly in contact to the balloon that you have in the other branch and at the level of the carena. And if you do that, I think at the end you will have a very good result, and you have no carena, no narrow carena, which I think is better for the patient. But of course, if you have any doubt, you can do a tap technique. The other question was
on the IVUS imaging, whether you decided not to use it also after stenting.
Yeah. So of course, it's a very important question too. So I think it depends on your experience in left main stenting. So if you are doing more than 20 left main every year, maybe you don't need it in all cases. If you are in the learning phase, of course, you should use it before and after, and before when it's not dangerous for the patient, but at least after. And if you have any doubt during the procedure, if something is going wrong, you should use also intracoronary imaging. I think it's very, very important.
Yeah, thanks. Our audience considers you as experts for IVL as well. So there is a question whether the use of IVL will damage the polymer if you use IVL shockwave after stenting.
Yeah, it's a very big question, and the company does not like the fact that some operators are using IVL after mal-deployment of the stent. We don't know exactly what will be the impact of that. But what I have to say is that sometimes you have a patient who had a stent which was implanted 5 years ago, and he had restenosis because the stent was not well open. And sometimes you have no other way that IVL to be able to open the stent correctly. Sometimes we use non-compliant OPNNC balloon up to 45 atmosphere without the possibility to open the stent, and then IVL can be very useful to do it.
As sequential tool to use. Thierry, practical question from Randa Tabak. What about the mid lesion in the LAD? It seems there is another mid lesion, probably one after the septal branch.
Yeah, it's a good point. So remember that this patient is 86 years old. She had no symptoms 2 years ago. So the plan was to do an MRI at 3 months just to check that there was no residual ischemia, no residual significant ischemia that may need more stenting.
So adenosine stress MRI in 3 months.
Yes, absolutely. Absolutely.
Okay.
But no, we have not done FFR in this particular case.
Yeah, Thierry, I think I used most of the questions, and now there is a group of questions that you will like the most. Why not DK crush from the beginning? Is DK crush still the best technique for two-stent strategy in left main? DK crush better than culotte from trials? I think all three of us should express our position on this kind of statement, because I just moderated a couple of weeks ago a live case from India, and there was ostial LAD lesion, and they did OCT. There was some moderate disease in the circ, no disease in the left main, and strategy was DK crush. So I think for our audience, for our colleagues, I think we should share definite personal perspective on the strategy and the importance of final result rather than strategy selection to achieve it, because long-term clinical outcome is determined by the quality and optimal procedural result, not by specific technique to be used. And at least in my practice, if I can start, in my practice, I try to understand the anatomy, plaque distribution, importance of lesion preparation. Imaging may help. Still, in majority of left main cases, we rely, of course, not in acute case like and unstable case like this one, but in majority of elective cases, we really recommend image-guided left main PCI. I think people can only benefit from the use of imaging. And then a selection of strategy is based on your personal experience. I was really positively surprised by reading recent article from British Cardiac Intervention Society in JACC Interventions, and I spoke with Adrian Benning and Tom Johnson as well. So if we look criteria required for operators participating in DK crush trials, so more than 300 PCI per year in the last 5 years, more than 25 left main of them per year. It seems that in publications in UK, only 6 out of more than 800 operators fulfill criteria to participate in DK crush trial. I think DK crush is a great technique, but you need to have experience and you need to know the 7 steps that Prof. Tan will clearly denote and explain later on in his case. But from my personal perspective, I have a long-lasting experience with provisional stenting or inverted provisional, and then in case of diffuse disease, I would still do in my lab culotte, and I'm sure that optimal result checked by IVUS will guarantee good long-term clinical outcome. And I don't know, maybe Prof. Tan, now you can express your perspective, and then Thierry, before we move to the second case.
Goran, I agree with everything you have said. I just want to add that many a times the strategies for intervention in bifurcation lesion is also morphology dependent. Depends sometimes on the angulations of the two vessels to decide what is the best strategy. And also from the experience that we gather, or at least the evidence we gather from definition 2, and perhaps also a little bit of DK crush 5, is that simple lesions should be treated simply. Provisional stent approach. Complex lesions needs to be treated with a complex 2-stent strategy. And to treat complex lesion with simple strategy is really a bad decision. So I think one will have to define the complexity of the lesion and pick a strategy and a technique that you're most comfortable with and that you're able to do it the best. And I think that will work for all your patients.
Thank you, Prof.
Yeah.
Tan. Thierry?
I fully agree with what you said. I just want to add very simple rules. So when we can treat a bifurcation with one stent, we know that the better than two stents. So that's why we are using the provisional approach. So we escalation of complexity, and at the end, maybe we'll end the procedure with two stents. And what is unfair in the Decacroche trial, for example, or in the other studies showing that Decacroche is better than the other technique, is that the strategy was comparing provisional without a stent in the side branch to complex patients to Decacroche. When you look at the mean lesion length in both studies, it's 17 or 20 millimeter in length. So we cannot treat a left man with a side branch or the circ, for example, which is 20 millimeter lesion, which is 20 meter in length, with only one stent. Of course, we need two stents. So we are comparing two strategies, provisional with 40 to 50% of patients who have two stents in very complex lesion, to systematic two stents in very complex lesion. Or of course, Decacroche is winning, of course. So it's a misunderstanding of what is a provisional approach.
Thank you. Thierry, two short questions before we move to Prof. Tan case. Why you selected femoral instead of radial? First question. Second one, what was the APT regimen that you decided for this lady?
Yeah, so it's a very important question. So we moved to femoral because access toward the radial, which was done for the coronary angiogram, was very complex. A lot of tortuosities and calcification. So we wanted to have something very, very easy to do because of the complexity of the left main, and that's why we moved to femoral. For DAPT, our strategy was to give at least 6 months of DAPT. But I think it's enough. So even in this complex lesion, we have only two stents. We have no neocarina, so the risk of stent thrombosis is very low.
Thank you very much again, and congratulations on extremely complex PCI, really done in very didactic way. I think we learned a lot from you. So I would like to ask now Prof. Tan to take control and present his challenging left main case. Prof. Tan, floor is yours.
Thank you very much, Gaurant. The case that I'm presenting here is an 82-year-old Malay male with diabetes as one of his major risk factor. And he was admitted with a late presentation for his acute anterior myocardial infarction just a week ago, and that was complicated by acute pulmonary edema. And the transthoracic echo shows a severely impaired LV systolic function with LVEF of 35%. But nuclear viability scan shows that there was still viable myocardium in the LAD and the circumflex territories. And so that prompted a heart team discussions for his anatomy. But however, patient has from the very beginning has refused coronary artery bypass grafting as an option of treatment. So this is his electrocardiogram, which basically shows a poor R-wave progression in the anteroseptal leads of V1 to V3 and lateral ST segment depression that you cannot see. I want to show the right coronary artery. This is a severely diffuse disease with a chronic total occlusion of the distal RCA at the distal segment. This is the culprit lesions, the LAD lesion. The LAD, as you can see, is a very high grade, 95% diffuse stenosis with actually a TIMI grade 2 and degrade flow. On top of that, you can see that there is an osteocircumflex stenosis with another lesions downstream at the first obtuse marginal vessel. This is the RO caudal view. And we'd like to look at the spider view now, again showing this very critical lesions involving the LAD and the circumflex artery. So I'm just going to pause here and perhaps ask my two fellow colleagues, what is your strategy for this particular lesion?
Thank you very much, Prof. Tan. Thierry, if this case is in your lab, what would be your strategy?
So we'll do something very close to what we have done in the previous case. So pre-dilate, wire both branches, pre-dilate the LED, stent from left main to LED, and then open the strut toward the circ. And probably we'll use two stents in this case, or maybe a 90% chance that we will use two stents in this case. In the T-shape configuration, I'm sure that we will use a culotte instead of a T.
Yeah, thanks. Of course, I agree completely with you. It's even easier to say first stent goes towards the culprit, which is LED, definitely. In this case, optimization inside the left main, recross distally, and I'm almost sure that in this case, I may stop with T or TAP, depending on the possibility to really cross through the very distal cell. If we are able to really cross the very distal cell, when we inflate balloon, we push some struts and scaffold partially the ostium and create favorable configuration at the ostium of the circ. That is actually the mandatory in order to position stent in the circ with minimal protrusion. But as you said, we have three options: T, TAP, or culotte. In case of culotte, it will be minimal culotte. Mini culotte with minimal protrusion and minimal overlap in the proximal part of the vessel inside the left main. So let's see. So I think this is very important. We all agree that both cases are angiographically very complex. Most probably in both cases, we start thinking of two-stent strategy from the beginning, and there is just some small individual difference in strategies, but at the end, we all aim for achieving optimal procedural result. So, Prof. Tan, you said DK crush. Please lead us through the steps of double kissing crush in 2020.
Yes. So, Gaurang, I chose DK crush for a variety of reasons. First of all, the anatomy suggests that there is a big discrepancy in terms of the size of the side branch and the main vessel in the left main. And secondly, because this gentleman has just had a acute myocardial infarction involving the LAD, and I can't afford to have a side branch that closed down on me. And I think DK crush offers that safety where I can secure the side branches always, and then intervene in the left main LAD artery. And thirdly, also is that I like this concept of a wire remaining in the main vessel. In this case, it will be the LAD throughout the entire procedure in the DK crush technique. And so for that reason, I choose DK crush, also because obviously this is a very complex lesion. So I think to understand DK crush, let's remember that this is really a 7-step procedure. So it takes a bit of time and multiple steps to do it well. Starting out with a side branch stenting, then you crush it with a balloon in the main vessel. Then you do your first kissing balloon inflation, followed by a main vessel stenting. Then you do a proximal optimization technique port, followed by a second final kissing balloon inflation, and followed by a report. So a 7-step procedure in this technique. And so like the previous case, I also put in an IBP because this patient has got a severely impaired LV function. And I just don't think that I want to risk any sort of hemodynamic compromise during the entire procedure. And so I went by the common femoral artery so that I can use a 7 French guiding catheter. And so what I did was I put in a wire in both the LAD as well as the circumflex, dilating the LAD first with a small balloon, a non-compliant balloon, because the lesions looks really calcified here. And also the disease looks really very diffuse as well. And the LAD also looks very small caliber. So I started off with a small balloon just to establish some forward flow. And then I started also dilating the circumflex with another NC balloon, in this case, 2.5 by 15, dilating both the OM as well as the osteo circumflex lesion. And this is post-circumflex and LAD balloon dilatation. We managed to achieve some flow down both artery. This is another view here. So what I do now is I put a long stent, 2.75 by 38 millimeter stent across the circumflex into the left main, packing also a non-compliant balloon, 2.25 by 15 across the LAD artery. So this is in preparations for the side branch stenting. So this is a spider view, again seeing the positions of the stent as well as the balloon. Next, we have the stent being deployed. I typically deploy it to high pressure here, 16 atmospheres or something like that to achieve a good stent apposition. Then I use the balloon which was sized to the distal LAD artery 2.25 to do the initial crush. And this is followed by a sequential crush with a larger non-compliant balloon of 4.0 by 10 in the left main artery. The reason for this sequential crush, which is a relatively new technique here, is that the initial crush with the smaller balloon is not going to be able to optimize the complete crush so that will facilitate your wire entry recrossing. So it is important to make sure that your stent is fully crushed with a larger balloon in the left main. And having done that, the next important step here, I think that differs, that distinguish a DK crush from a keloid stent is that you want to recross using the proximal cell of the stent. And if you look at the pictures on the left side, if you cross the proximal cell, you are likely to be able to push some of the metals to cover the carina. But if you go by the distal cell, you might actually miss some of the coverage of the carina with the crush stent. So the idea here is to leave the original wire in the circumflex here in the side branch here. Using that wire as a marker, you track another wire down using the same first wire as a marker. And in this case, you will surely go into the proximal cell of the stent. Once this wire has gone through successfully, you can then withdraw your trap wire and you can do your first kissing balloon inflation. And this is what I did. So this is first kissing balloon inflation. This is after kissing balloon inflations. We see that the circumflex stent is now in position. LAD artery is fairly open up here. This is after the kissing balloon inflation. Certainly, if you can see that the LAD requires a bit of work, the disease is very diffuse and extensive. And so this is what I did. I did a sequential overlapping deployment of two stents, a smaller stent in the distal part and a bigger stent in the proximal part. And then we do the second kissing again, passing now a guide wire through the middle or either the proximal or the central part of the stent in the side branch, and then crossing in to do a kissing balloon inflation. Again, we follow this concept here of a sequential, this is a port following the second kissing balloon inflation. And this is the final angiography. Stent looks pretty well deployed. This is the spider view, also looks very well deployed. And again, this is again guided by intravascular ultrasound, which shows a pretty good MSA achieved during the entire procedure. So this is the final results. Thank you.
Congratulations, Prof. Tan. Really looks great. And there are a few questions that I didn't want to interrupt your presentation of procedure. I think it's very important to see the whole procedure. But the first question is related to bifurcation angle and selection of DK crush. Usha is asking if angle is too wide for DK crush. Normally, it's suggested in range 40 to 70 degrees. And the second question is how you select which is the main branch, which is the side branch, because of the vessel size.
So very good question, actually. So to answer the first question of, so the first question was again, come again, Goran, could you just remind me the first question?
Bifurcation angle, is it too wide? Okay.
The thing about a DK crush is that actually it is suited for all angles. If you can use it for a very narrow angle lesions, or you can actually use it for a very big angle lesions. So that is the versatility of this particular technique, as opposed to perhaps a T-stand and so forth. The second question here is that deciding which one is the side branch and the main branch. I think
Which one
I would I would generally use the the smaller branch of the bifurcation lesion as the side branch for the technique. So in this case, circumflex subtens is obviously a smaller territory here. I'm going to use it as a side branch here, and then and then use the LAD as the main vessel. This technique actually preserves the patency of the side branch. So whichever vessel you choose, you're going to be sure that you're going to have access to the vessel even throughout the entire procedure.
Yeah. Next question is related to proximal cell recrossing. Question is, do you need OCT to ensure that your wire is crossing the proximal cell in the crushed LC extent?
Well, you don't need intravascular imaging all the time. You can use OCT. You can also use intravascular ultrasound. But like I say, if you use the original wire as a marker and you track your new wire very close to it, it's likely that you're going to be going into the proximal cells most of the time. So I don't think it's mandatory to check on your position. But if you're a purist, as far as DK crush is concerned, I know there are some purists around. They have to check every single procedure using imaging. So you can do that as well to make sure that you're truly in the proximal cell.
Yeah. For the benefit of all our people who follow this webinar, please try to explain why in DK crush, compared to every other technique in crush, we cross proximally or centrally instead of distally. What is the reason why we don't also use, like Thierry said, in TAP or in culotte, in T, a distal cell? Please help people understand the subtle difference in recrossing point.
Yeah, so remember, you're actually crushing the stent that is coming out from the side branch. If you go to distal, like a tab or keloid, you're going to miss some part of the stent where there's perhaps no coverage of the stent, enough of a stent material at the carina. But if you cross it, the proximal cell, much of the stent material is going to be shifted to cover the ostium of the side branch at the carinal side. And that's why we keep emphasizing from the bench study that has been presented by Chen Xiaoliang, is that if you look at it in the bench, you can clearly appreciate, especially in the picture that I showed just now, that if you go by the proximal cell, you will have ample coverage of stent, and that will provide the mechanical scaffolding as well as the drug distributions to prevent restenosis. So go by the proximal cell and perhaps look at the pictures to better understand it yourself.
Yeah, thanks, Prof. Tan. Thierry, do you have something to comment or add on this point?
Yes, I think there is another point which I think is very important with the DK crush. If you go through a distal strut, in fact, you have a risk of going outside of the stent, because especially in T-shape angulation, because the stent in the circ is like that. So you have a space close to the carina which is not covered, and you may go through the main branch stent through this state and then outside of the stent, and then you may crush the stent crush again, but not at the right place, the stent. So I think it's a very important point. I think there is very simple rules for the provisional. If you want to go through a distal strut, the best technique is to do a pullback technique. So you go back from the main branch, orientating the wire toward the side branch, and at one time you will see the wire doing this. And it's usually the distal strut. If you go from the proximal, usually you are going through the proximal strut immediately. So I think trying to go through the correct strut is relatively simple. Of course, you can check by intracoronary imaging, but we don't do it every day. So this pullback technique versus integral technique is very useful, I think.
Yeah, thank you very much for clarifying that. What I use in my routine practice is jailed wire. If I use provisional as my standard strategy, by implanting vein vessel stent, you actually push jailed wire. And if you select the angle which opens widely bifurcation, you can try to cross distally and observe small difference between two wires. And actually your distal recrossing will make 1 to 3 millimeters difference between jailed wire and distal crossing wire. In that case, you can make sure that even if you are not the most distal cell, you are certainly distal inside the ostium of the side branch. And I like very much the trick explained by Prof. Tan, that he is also using jailed wire, but in this case trying not to have gap between two wires and actually focusing the attention to go parallel with that jailed wire. Prof. Tan, please explain the concept of sequential crushing. People are afraid if you are using for sequential crushing large balloon, how you are deciding on the balloon size and what is the concept behind the sequential crush?
Again, a very important questions here with regard to DK technique. So in the initial crush, we are actually sizing according to the distal main vessel, because you don't want to size it to the proximal vessel and then cause massive dissections down the main vessel distally. So we always use the, so in this case, it will be the LAD balloon that we chose the size. It was a 2.5, 2.25 and 2.5 to crush to do the first kissing, to do the first crush. And after that, we will choose a largest balloon to do a further proximal crush. And this will be entirely guided by the intravascular imaging that you will have gotten. And I tend to prefer a non-compliant balloon in this case, chiefly because I would have known the size of the vessel from the imaging, so I don't have to go really oversized. I just need a high pressure here, making sure that the distal marker of that port balloon, the crush balloon, is right at the carina, so that I can have a good stretch of the vessel and crushing the stent and press it against the side of the wall. And so this will be the concept here, that you will try to achieve as much of a good port here or a good crush here, so to speak, in the first instance, not only to facilitate the entry of the wire into the side branch, but also subsequent entry of the stent into the main vessel as well.
If I may try to summarize modern DK crush, so you actually do 3 times pot and 2 times kiss.
Yes, actually, I would encourage you to do as much pot as you can, so you don't have to strictly go by the 7 steps. If at any point in time you're uncomfortable with the results that you're getting from the crush or the pot, by all means do a pot first, because it will always give you the best outcomes.
Okay, please tell me, there is also a question regarding the risk for left main dissection during the first kiss. If you are using large balloons and left main is not stented, when you do the first kiss, you are definitely oversized. Please help us understand how you select balloons, what pressure, sequential or simultaneous inflation, deflation. There are multiple questions on the sequence of kissing.
Actually, during the first kissing, we are sizing it according to the daughter vessel, according to the LAD and the circumflex artery. So it's unlikely that this will be so big as to cause the dissection in the left main. Again, the procedure is being guided by the images. You will have a clear idea of what the size of the left main here. So if you are very worried about, I will say that you go on the conservative side. Try not to oversize the balloon that you're choosing for your 2 vessels. And you can always come back with a larger balloon for your port, as you call it. Yeah. So size it to the daughter vessel here.
Yeah, thanks. Difference between nano crush nano DK crush and classical DK crush, there are now intentions to make it smaller and smaller. What is the nano crush? How you do nano crush?
So as I understand, nano crush must be a minimal protrusion into the main vessel so that you have least materials inside the main vessel to crush. But I have to caution here that this technique requires you to cover the ostium of the side branch completely here. So if you put in very little into the main vessel, you run the risk of actually not covering very well the ostium of the side branch, and then defeat the entire procedure. You might just convert it to a T or something like that. So we recommend a 2 to 3 millimeter of protrusion from the side branch into the main vessel. If the angle is too small, you might actually have to extend a little bit more than 3 millimeter. But I would say that between the nano crush and the typical DK crush of 2 to 3 millimeter, there's really not much of a difference as long as you do the procedure well and step by step.
Yeah, perfect. So recommended protrusion of, it's also a question from the audience, recommended protrusion of the side branch stent is maximum 2 or 3 millimeters inside the left main. I congratulate you both on fantastic cases. Any final remarks or comments from both of you?
Thierry?
I think the most important, in fact, is to stent the left main with one stent when we can do it, but of course to use 2 stents when we should do it. And I think it's very simple because we know that when the lesion is longer than 10 millimeter in the side branch, the outcome is better with 2 stents, clearly. So it's relatively simple, and then follow the simple rules that we have described, which are published in the consensus of European Bifurcation Club since a long time. And by following these simple rules, you will succeed in the vast majority of cases, not acutely, but also at follow-up.
Thank you very much. Prof. Tan?
I would say that in dealing with bifurcation lesions, one of the most important criteria is to establish if the side branch is really important enough for you to consider intervention. And this has to be judged from not just the morphology, but also from the physiological, from the clinical, as well as the prognostic factor. And this is actually the consensus statement from the Asia-Pacific bifurcation group. And having decided that this side branch is important enough, then you have a whole variety of techniques here. And this is where the stratification, the risk stratification of the complexity of the disease comes in. So I said before, simple lesion, treat simply. Complex lesion has to be treated complex in a complex fashion. And in this way, I think we'll get the best results.
Thank you very much to both of you. I would like to conclude this one, and if I can have my final slide. Today, we discussed how to treat left main stenosis, focusing on the selection and execution of the stenting technique. So elective 2-stent strategies may be considered for left main PCI for important side branch with complex and extensive stenosis, for difficult side branch access or high risk of side branch compromise. Stenting technique should depend on individual patient's anatomical characteristics, but of course on the operator experience and skill. Among 2-stent techniques, there is already strong randomized evidence for DK crush, while European Bifurcation Club left main results are eagerly awaited, and we will be very happy to share those results with you at the next PCR 2021. So I first of all would like to express that I'm so privileged to moderate this session with 2 of great interventionist friends and very experienced people. I thank you, Thierry. I thank you, Prof. Tan. I would like to thank all the audience for supporting us and sharing questions and comments with us. And I would like, of course, at the end to thank Medtronic for supporting this bifurcation continuum. Next webinar on bifurcations will come soon. Please follow us on PCR Online. I thank you very, very much for sharing today with us this webinar on left main PCI. Thank you and have a great day.